All right, we are live.
Yes, hello everybody. Good morning, good afternoon, good evening, depending on where you are in the world. My name is Macartney. I'm the president of WSPID, and this is the second of our WSPID webinars. Our theme at the moment is COVID-19, which is affecting all of us in our personal lives, with our parents, families, and of course the extremely vexing and difficult question of what to do with schools. So we have arranged a webinar with experts from Australia and South Africa to give us more information and more data on which to base our decisions. And we are really looking forward to this webinar. If I could have the next slide. I briefly wanted again to introduce WSPID to those who don't know it, the World Society for Pediatric Infectious Diseases, represented by regional and local pediatric infectious diseases societies throughout the world. And if you look at the top right, you can see that our next meeting is scheduled for December 2021 in Cancun, Mexico. And it will either be live, online, or a combination, depending on how things are going with COVID and whether there's a good vaccine available in time for all of us. Please keep that in mind. Next slide. WSPID, apart from the biennial meetings, which are really excellent, prepares and plans for the meetings in the intervening years, plans a workshop, has an antimicrobial resistance working group, has a very active education committee, and we are currently working on a portal for the WSPID website. Please sign up to the mailing list to keep updated, and please participate. Next slide. Please submit questions through the Q&A. We already have questions that have been pre-submitted that our panel will address. We are really looking forward to this webinar, and I think we're all going to learn a lot. So next slide, please. My co-chair is Professor Fiona Russell, Director of Child and Adolescent Health PhD Program, University of Melbourne, and extremely active in pediatric infectious diseases and COVID with WHO collaborations. And Fiona is co-chairing with me and will take over for the next part of the webinar. Thank you very much.
Wonderful. Thank you, Mark Cotton, and thank you so much. And I'm, as Mark said, I'm Fiona, and I'm based in Melbourne. So welcome to you all. And it's really wonderful to have a combined seminar really with our South African colleagues and also Australians, which is a Southern Hemisphere sort of collaboration, which is wonderful. And we're joined by our terrific panel. So I will introduce them. And so firstly, we have Dr. Archana Koirala, who's a pediatric infectious diseases physician, pediatrician based at the Nepean Hospital and also at the National Centre of Immunisation Research and Surveillance. And we have Professor Ameena Goga, who's the Director of HIV Prevention Research Unit at the South African Medical Research Council, and also a paediatrician in respiratory medicine in the Department of Paediatrics and Child Health at Steve Biko Hospital, and also at the University of Pretoria. And Archana and Ameena will be giving presentations, And in addition, we have Professor Kristine Macartney, who is the Director of the National Centre for Immunisation Research and Surveillance in Australia, and also a paediatric infectious disease specialist at the Children's Hospital in Westmead, and also has her professorial position at the University of Sydney. So I think we'll go now straight to our first speaker, who's Dr. Archana. And so Archana is going to be speaking on the available evidence on the issue of schools as a driver for epidemic spread. So thank you very much, Archana, and over to you.
Thanks, Fiona. Okay. Well, thank you so much for the opportunity to speak. As Fiona has mentioned, I'm a paediatric infectious diseases doctor based in Sydney. And my topic is SARS-CoV-2, are schools a driver for epidemic spread? I work with a group of amazing people at NCS, and the research that we've done in New South Wales Health was kindly funded by the New South Wales Government Department of Health. I don't have any otherwise conflicts of interest or disclosures. Well, I'd really like to begin by acknowledging the traditional custodians of the land on which we all meet on today and pay my respects to their elders past and present. So welcome. I begin my talk. As we all know, COVID-19 is caused by the coronavirus, which emerged in November, December, and was noted initially in Wuhan, China, but quickly became a global pandemic with currently 42 million cases and around 1.2 million deaths. Its impact on education has been paramount. You can see in this figure that since March 2020, a number of schools have remained closed, partially open, or open for a brief period of time. At the beginning of the pandemic, up to 87.5% of the school-age population were affected. And this is a good slide from the UNESCO COVID-19 impact on education that you can have a link to. So what are the possible benefits of closure of schools? Well, really, it's intended to reduce viral transmission. It reduces the travel and movement of people. Children we know can have mild symptoms. Many can be asymptomatic. And there is a concern whether they would bring it home to the family and infect their families and their elders in particular. We suspect that limiting introduction of this virus to a setting where kids are unable to be physically distanced, and we also want to ensure that we protect our teachers. But there are a whole host of adverse consequences to closing schools, including the interruption of learning. There's confusion and stress for teachers trying to adapt to a new learning environment. Parents are unable to work, and it has a big economic impact. It increases education disparity. We find that there's a rise in dropout rates and reduction in return to school. It's socially isolating, and kids are at increased exposure to vulnerabilities at home. So this is a recent headline from the BBC that shows in schools, in certain schools in Kenya, because of the economic impact, classrooms have been turned into chicken coops to ensure, that the school has a capability of making some money. But really the question is, does closing schools reduce viral transmission? Or perhaps does keeping schools open or reopening schools increase viral transmission? And there have been a number of reports and studies that have been reported globally. I start with the Republic of Ireland, and really the first Irish case of COVID-19 was noted in a school-age child in March 2020. They found that there were 3 pediatric cases and 3 adult cases who attended the school. And there were 1,155 contacts, including classrooms, sports, music, and choir. And all symptomatic cases were tested, and they found that really there were no secondary cases. We move on to Israel. Now, Israel reported 2 index cases in a high school upon return to school. This included around 1,000 students and approximately 150 staff members. They did have mitigation procedures in place, including increased hand hygiene, the use of face masks, social distancing, and class bubbles. They tested the entire school, and in this setting, they found an additional 153 students and 25 staff members to be positive. When they investigated the potential cause for this transmission, it was noted that the classes were highly crowded, up to 38 students. Israel was experiencing an extreme heat wave, and that there was continuing air conditioning. I move on to the United States of America. And really what the USA have noted is that there have been an increase in new child and adolescent cases with the school year restarting. Currently, children make up to 10.5% of all cases. Yet children only make up 1.8% of hospitalization, illustrating that children can get infected, although the majority may be asymptomatic or mild. A recent study that's been published in Pediatrics surveyed approximately 57,000 childcare workers. And what they found was that there really wasn't any difference in getting COVID-19, whether you continued to work in a childcare. However, it was noted that home-based childcare providers was associated with an increased odds of getting COVID-19. And perhaps there is a difference between the home and a school environment. I move on to the United Kingdom. In England, they restarted a summer mini term after the closure of schools in the early part of this year. They implemented mitigation strategies, including smaller class sizes, social bubbles, so groups of kids only interacted with a certain number of other kids, and frequent hand washing. Primary schools and preschools returned, and really what they found was that what they found were approximately 101 index cases. So these are introductions into these settings. Of those, 70 were students and 28 were staff. 4 were co-primary cases, so siblings within the same household. But what they found is that in 67 settings, there really wasn't any secondary cases. And there were, in the 30 settings that did have a secondary case, only up to half of them only had 1 secondary case. What they also found was the outbreaks occurred in areas where there was increased transmission. So it correlated with regional COVID-19 incidents, but the risk of outbreaks within the school setting was low. Another study was conducted, once again, within the summer half term. So they tested a number of schools within England, and they did weekly nasopharyngeal swabbing, and certain schools also had a blood test to test for SARS-CoV-2 antibodies. In total, there were approximately 12,000 participants in 131 schools, and 43,000 swabs were taken. What did they find? They found 3 additional cases with this testing, 1 student and 2 teachers. Really, there were no additional cases in the households of those 3 cases, no additional cases in the class bubble or the wider educational setting, indicating that transmission within the school setting was likely to have been very low. In schools that participated in serology, or the testing for SARS-CoV-2 antibodies, they found that the prevalence of antibodies were similar in students and staff, and both were similar to the underlying prevalence in the community. What's happening in England now? Well, we know that there has been an increase in the number of COVID-19 cases, and as you can see in these graphs, there has been a particular increase in the adolescent age group, as well as the young adult age group. And this article just highlights that 400,000 children in England have been off school in 1 week due to an index case being introduced into the school setting. I move on to South Korea. Once again, schools restarted face-to-face teaching on the 20th of May. They also put in mitigation strategies, which included plexiglass between students, especially at lunchtime, the separation of plexiglass within the classroom, and physical distancing in the corridors. And what they found was that there really wasn't any sudden increase in pediatric cases after school reopening. They did find that there were students that, became index cases, so they introduced the case into the school setting. But when they tested over 11,000 students and staff, they found only one additional transmission in a school where one index case transmitted to 2 other students. Now, notable in this literature was also that they noted that extracurricular activities, such as participating in a drama class or a singing class outside the school setting, seemed to be a source of transmission where those students once again reintroduced it into the school setting. So I move closer to my home. So I'm going to talk about Australia, the Victorian story. So it's a state that's adjacent to where I live, New South Wales. And what they found was that they found approximately 1,600 infections linked to early childhood centres and schools out of a total of approximately 20,000 cases in Victoria. 66% of these really involved only a single infection in a staff member or student, and 91% involved fewer than 10 cases. So really, what they found was out of 1 million students enrolled, only 337 may have acquired COVID via an outbreak at school. This graph also illustrates that introductions in school, as I've illustrated in my previous slides, seem to occur with underlying incidence of disease. So when you have high transmission within the community, high or moderate transmission, you will find that there will be an increased introduction into the school setting. I move on to New South Wales, where I live and work. It has a population of 8.1 million, and 1.8 million are under or equal to the age of 18. We have around 3,000 schools, 140,000 staff members within these schools, and 1.2 million students. We have an approximate number of childcare at around 4,600 childcares within the state. So what did we find? Well, this is an epidemic curve of our curve until September. As you can see on the curve, that within term 1 of our school term, that we had our highest wave. The majority were introductions from overseas. But as a consequence, public health mitigation strategies were included, including border closures, bars and restaurants being closed, and a ban on overseas travel for Australians. Schools remained open, but there was decreased attendance between late March to mid-May. And there has been high attendance ever since, even during a moderate increase rates of transmission within our term 3. When schools restarted, they limited parents on site. There was additional cleaning and hand hygiene measures implemented. There was limits. They tried to limit interactions between the stages. So, for example, between a 7th and 8th grader versus an 11th or 12th grader. So lower high school and upper high schools. But this was difficult to implement, especially in the primary school setting. There was no physical distancing of students within the classroom, but physical distancing were encouraged amongst teachers, especially in their staff room. Masks were not worn, but encouraged on public transport. In around August, there was also some limitations to sport, so only playing sport within your community or your zone, and some restrictions to singing and music playing. And in New South Wales, from the beginning, we implemented a public health response, which involved education, research organizations such as ours, and the New South Wales Health, so the public health units. So when there was a case, it would trigger a public health unit and trigger a conversation between the Ministry of Health, the Ministry of Education, and the public health unit, as well as the school. A contact list would be formed, and usually children or staff members who shared a room for approximately an hour with the student or 15 minutes face-to-face were deemed as close contacts. During this period, as we were trying to find out a contact list, the school would be closed and cleaned. We were then involved and the contacts were followed up with, and this evolved as the pandemic evolved, or the epidemic within New South Wales. But what we have recently implemented and occurred for the majority of term 3 is early nasopharyngeal swabbing, so an early nucleic acid test, as well as a nucleic acid test or a PCR test at approximately day 10 to day 11 prior to the re-entry into the community and the school after 2 weeks. We also offered enhanced investigations, including serology at approximately 1 month after potentially being exposed to look for infection. And then we identified them as being, if anyone was positive on the nucleic acid testing or serology, they were deemed after careful interviewing as a secondary case. So what did we find? And I apologize, this is a busy slide, but I'll go through it clearly, and I'm close to the end of my talk. So in term 1, we found that there were 27 primary cases in 15 schools and 10 early childhood settings. In terms of secondary cases, there were 12 students and 15 staff members, and really this occurred within a high school, minimal within high school and primary school settings, and one early childhood setting had all the secondary cases. So 9 early childhood setting had no secondary cases. In term 2, the transmission in the community was very low. We had 6 primary cases in 5 schools and 1 early childhood setting, and we had no secondary cases. And in term 3, we had some community transmission, especially in certain areas of metropolitan Sydney. And we found that there were 39 cases in 28 schools and 6 childcare settings, and secondary cases of 28 students and 5 staff members. And the majority of secondary cases occurred within 3 high school settings. And I just want to bring your eyes to, initially in term 1, testing rate was only 40%. And you could argue that, potentially you didn't survey the entire population and you may have missed asymptomatic infection, because testing was advised if you developed symptoms. But in term 3, because we were testing all close contacts and testing rates were up to 95%, we still saw very low cases of transmission. So this shows, so the additional numbers on the bottom just shows that the rate of transmission within a high school setting was approximately 0.9%. The rate of transmission within a childcare setting was 1.4%, and really this is skewed by that one childcare that had an outbreak very early in the epidemic, where testing criteria were quite narrow and potentially staff members who may have been infected attended the childcare for a number of days. And in the primary school setting, really it's the lowest rate of transmission at 0.4%. And overall, it gives us a transmission rate of less than 1% in school and early childhood settings. So this is just similar to my previous slide. What it does suggest is that a primary school child, if you've got a primary school child who is an index case, the likelihood of that primary school child transmitting is 0.2%. It's slightly higher in a high school setting. We know this because high school students, are similar, have potentially similar transmission rates as adults. Yet an adult in any setting has the highest rates of transmission at 6.4% to another adult. I'm just going to try to talk a little bit about when the outbreaks occurred, what potentially were contributing factors. Well, in term 1, really a large outbreak occurred in one setting. And contributing factors were potentially delayed primary case diagnosis because the definition of testing was quite narrow. There was a combination of classrooms within this childcare and a close mixing of staff and children as well as shared physical amenities. In term 3, we noted that the majority of transmission occurred in high school settings. And potentially there were sentinel seating events. Attendance while symptomatic seemed to correlate potentially with transmission. And, if an index case had increased contact hours with their close contacts, that occurred in one setting where there were a number of secondary cases. So really, it's really important to strike a balance. It's important to understand how many cases have attended a school while infectious, the mitigation procedures that schools have put in place to prevent the transmission of COVID-19. But it's also important to know how schools respond to an infectious case and the rate of secondary transmission. Certain activities may contribute at a higher risk for activities such as singing and choir practices, and really outbreak reports have been reported in adult choirs. Sports, close contact sports, and potentially overnight camps or overnight stays. So in the interest of time, I'm just going to go to my conclusion slide. Really, the likelihood of seeing a case attend school is proportionate to the extent of community transmission. Transmission within a school setting, when examined or researched carefully, seems to be low. But this is in the context of a strong public health and education response. And really, it seems that schools overall do not seem to be the drivers of infection, but transmission can occur. And when it does, it seems to be more likely between staff or high school students. School-based activities really need to be aligned with community incidence of disease. And an early identification of a case is correlated with lower risk of transmission. So the importance of testing early and contact tracing early. A coordinated health and education response is vital. And really, the closure of schools and the uncertainty of a pandemic increases stress and the mental health toll of everyone. So thank you so much for listening to my talk, and I hand it back over to Fiona and Ameena.
Excellent. Thank you so much for that, Archana. And as I mentioned, we'll take questions at the end. There's a few there in the chat box and also in the Q&A as well, some questions. And we will now have our second panel speaker, Professor Ameena Goga. And Ameena is going to talk about an in-depth analysis of delaying school physical presence on psychological, emotional, social aspects of children. So thanks so much, Ameena. And if you'd like to unmute your...
Thanks. Yeah, thanks very much. I'll just try and share my screen. Does it show on your side?
Yes, all good. If you just want to make it full screen. It's coming up slowly. Yep.
You know?
Still, yeah, perfect. Thanks.
Okay. Thanks very much, and thanks for the introductions. And good morning, good afternoon, and good evening to everybody. So I'm going to be speaking about the non-physical, the effects of non-physical attendance at school on children's health, with a particular focus on mental, psychological, emotional, social, and physical health. As I mentioned before, I'm from the South African Medical Research Council. I do have just one thing to disclose, and that since the COVID epidemic, we are participating in a Novavax COVID-19 clinical trial to test a vaccine, but that's the only disclosure that I have. For my presentation, I'm going to make 3 main points, and I'm going to take you through a series of expert opinions, statements, as well as some data to substantiate the points that I'm going to make. The first point is that let's leave no child behind. Physical school aims to grow individuals that transform society by focusing on verbal and mathematical skills, physical, mental, and social health, and critical skills. Secondly, that non-attendance is associated with hunger, poor mental and physical health, increased child mortality, fertility and pregnancy, exacerbation of gender inequalities, and exposure to violence. And thirdly, that as part of the SDGs, and particularly the 4th SDGs, focusing on education, we do have a global imperative to offer physical school attendance with precautions during COVID-19, or to reimagine schooling by creating physical learning pods, or to increase the coverage of online platforms that recreate school environments with a particular focus not just on the transactional part of learning, but also on relationships. So as I go through this presentation, I'll substantiate why I think these are the main points that we need to consider. So let's just think about the history of schooling. Why do children attend school? And that's what I'll cover first. I'll then move on to the effects of non-physical school attendance at an individual level, so the level of the individual child, followed by the global level, and then I'll focus on a way forward. So to start with, why do children attend physical school, and what resulted in public school health systems? And really speaking, if you go back and look at the history of the development of public school systems, they were influenced by religion, economics, and social class, colonization, as well as government policies. And ultimately, it was thought that physical school attendance was needed to observe and scientifically discover natural laws of the universe and create a reasonable man. It was also thought that man learns best through sensory experiences. So there have been several declarations in countries declaring that primary school is compulsory, that schools should offer a standardized curriculum, that there should be no less than a specific number of days of school per year, that schools need to include concepts on human rights, the environment, dangerous drugs and computers, that schools need to offer regular sports activities, as well as the teaching of music. And so in general, school attendance and physical school attendance is supposed to contribute to the holistic development of all children at little or no cost to families, to ensure children's mental, physical, and social health and well-being, and to grow individuals that make meaningful contributions to society. But there are two sides to the story. Should schools be closed or should they be open? And this is just an example from our newspaper in South Africa showing these two sides of the story, two articles published on the same day, the 18th of October. The one says online schooling at home in a class of their own, and the other one says knocked out, locked down. And the essence of these two stories is that for the first one, locked out, knocked down, or knocked out, the article says that as time wore on with lockdown, tedium and fatigue set in, so did paranoia. Many people had the illogical suspicion that everyone had reconvened and they were the only ones communicating via Zoom or WhatsApp. Then the article about at home in a class of their own refers to children who are doing online schooling, who are getting better marks, who are performing better than they did in their previous school, with a statement that the child is not missing the social interaction because kids have their webcams on and they're talking to each other during lessons. So it's pretty much like normal school. But really speaking, if one looks at the effect of non-physical school attendance at the individual level, what do we see? Recent modeling studies have shown that even with COVID-19 and school opening, school closures alone would only prevent 2 to 4% of deaths, so much less than other social distancing interventions. Now I'm going to show you two statements by different organizations looking at the role of schools and the effect of school closures. The first is by the World Health Organization European region, and this statement says that children live in an unprecedented time. They face an enormous disruption to their lives. They're likely to experience worry, anxiety, and fear. And where schools have closed, children may no longer have that sense of structure and stimulation. They have less opportunity to be with their friends, so less social support, which is essential for good mental well-being. They may be at increased risk of or increased exposure to child protection incidents, or they may witness interpersonal violence if their home is not a safe place. The second statement is from the Centers for Disease Control and Prevention, and they highlight the critical role of schoolgoing, and particularly state that the in-person school environment not only provides educational instruction, but supports the child's social and emotional well-being and skills, safety, language and speech, behavioral and mental health by providing services, provides reliable nutrition, and opportunities for physical activity. So in essence, they state that schools provide important services and support for academic, social, emotional, and physical health, and that the continuity of these special services is important, and that lack of access to these services has the potential to widen existing disparities and cause long-term effects on children's educational outcomes. They also highlight the fact that experiencing feelings of isolation, depression, and anxiety, which is common while you're stuck at home, could raise the risk for suicide. I'm now going to look at COVID-19 and return to school, the need and the necessity, and present to you two slides. The first slide makes the point that schools have been closed in 143 countries, affecting more than 1 billion learners. Like the CDC statement and the World Health Organization statement, many authors have highlighted the fact that school closures have adverse consequences for learning, social and emotional well-being, and access to school-based services, that schools provide childcare support, enabling parents to work, as Archana mentioned in her talk, that school structure promotes child well-being, school closures have disrupted children's daily routines, and playful and physical exercise has been curtailed, and really speaking, there are no replacement options. The second slide is very busy, but you see the effects of, in red, the deleterious effect of school closures on your left-hand side, and on the right-hand side, several reasons why schools should open. So what are the effects of school closures on mental health? And here there are 6 slides in total. I'll take you through them. The first 2 slides highlight that expert opinion believes that children's mental health is affected severely. And these opinions come from all parts of the globe, East and West. So these are just quotations from the USA mostly that highlight the effect of school closures on mental health. And in particular, I want to highlight the fact that spending time online can exacerbate feelings of loneliness, agitation, anger, and despair. Secondly, I want to highlight the fact that teenagers seem to struggle more when they're cut off from their social networks. And thirdly, I want to highlight the fact that preschool is a time where children learn social skills such as sharing and taking turns, and this will compromise children's development. These are statements from the East now, from Hong Kong, raising exactly the same points. Explain the lack of school routines is resulting in children staying at home, refusing to take showers, eat, or leave their beds, and that children with special needs in particular can become very frustrated and short-tempered when their daily routines are disrupted. This slide also speaks to mental health from a different source though. It's from the Human Rights Watch, and it quotes children. So it interviews children, and all these quotes say that not going to school has been stressful. There's been no emotional or social support provided by schools, and that children have been completely struggling or crying. These interviews were conducted mostly with children in Africa. The next 3 slides focuses on research, so data from particular studies on mental health. The first one states that young children may be at a heightened risk of mental health issues when isolated from friends and teachers. This was an online survey conducted in Hubei province in China, enrolling 1,784 learners in grades 2 to 6. They were not at school for approximately 33.7 days. And of these learners, 23% experienced depressive symptoms, 19% experienced anxiety, and there was a 1.4 times increased risks of depressive symptoms with the longer school closures. There's similar findings from the Young Mind survey in the United Kingdom. This is the summer survey. There've been 3 surveys conducted. This is the results from the summer survey, which is the second one. They interviewed approximately 2,036 young people aged between 13 and 25 years old. Many of them had a history of mental health needs. And what they found was that for 80%, the COVID-19 pandemic worsened their mental health. For 41% of these, it made it much worse. 87% felt lonely or isolated during lockdown. 31% had no longer any access to mental health support. And 40%, who were not accessing mental health care before the crisis, now needed mental health support but were not accessing it. Only 11% reported improved mental health due to no bullying or no academic pressure at school. These are data from Italy, and the paper says that helplines have been extremely busy. During lockdown, the helpline dedicated to children registered a 14% increase in requests for mental health support and a 22.6% increase in the need for contacts by chats. The emergency services saw an increase of 25% of cases managed for abuse and violence. Now let's move on to social health and learning, and this is a statement from the Royal College of Paediatrics and Child Health in the UK. And the point they make is that distance learning could compromise social skills, and that learning from home and only interacting with friends and classmates virtually could negatively impact children's socialization skills. Similar findings on social and physical health have been found in Shanghai. This was a repeat survey of approximately 2,400 children and adolescents aged 6 to 17 years from 5 schools in Shanghai. The researchers found that not going to school reduced the number of hours that the children spent in physical activity by 7.3 hours per week. And there was a concomitant increase in screen time by about 30 hours per week compared with pre-pandemic numbers. Similarly, data from Pakistan shows that this was based on a rapid needs assessment. So these data showed that school closures may magnify rural-urban divides, gender inequalities, and socioeconomic divides. And the big concern in this setting was increasing child labor in the short and long term. So the solution or suggestion here was that schools need to focus on areas of nurturing resilience in children and adolescents, and that when children return to school, their mental and physical health will explicitly need to be supported. So similarly, another paper found very similar effects, showing increased physical inactivity and increased screen time, that a sudden change in routine has increased the number of psychiatric disorders, that the closing of schools may cause problems for children's nutrition, and to date, some schools have been closed for more than 200 days, and that closing of schools for a longer period may actually cause greater damage to society than their reopening with some care measures. And the number of papers go on, making exactly the same points from different sources, different countries, and different parts of the globe. This is a paper that looked at growth and development. And the main point made in this paper is that school closure may increase the risk of adverse childhood experiences and elevate the risk of toxic stress, and that these toxic stresses experienced by children may cause growth and development delays and possibly long-term health problems through to adulthood, including cognitive impairment, substance abuse, depression, and non-communicable diseases. What about hunger? A lot has been said about possible effects on physical health, and there are data that show that approximately 370 million children, 47% of these are girls, miss the provision of free subsidized foods through school, that 38 million children were acutely hungry in 2019, but this has doubled to 74 million in 2020. And of note is that hunger can impair the immune system, increasing morbidity, impairing cognition, and malnutrition. So all in all, this can ultimately affect human capacity development in all our countries. In South Africa, where I come from, in particular, the National School Nutrition Program provides approximately 10 million learners with meals every day. And these have been missed for a large part of the lockdown period throughout school closure. What about the female child? Girls have been could be disproportionately affected. There are no data on COVID-19, but there are data from the Ebola. And what these data show is that during school closures, pregnancy and child marriage increases. Children, especially girls, are exposed to domestic and sexual violence. And a large portion of girls are at risk of not returning to school when schools open. Are there benefits of online school? A difficult question to answer, but the papers that I've found said that controlling for known achievement risks, particularly children with special care needs or children from lower socioeconomic settings, may not benefit directly from online schooling. It's only when online schooling can be coupled with direct assistance and bridge the gaps with known disparities that online schools may emerge as a true educational alternative, particularly for at-risk populations. So what about the global level? And here I want to just remind us of the Sustainable Development Goals, that quality education is part of the Sustainable Development Goals. The second point I want to make is that pre-COVID, 258 million children were out of school. And with COVID, inequalities will be exacerbated, in particular in low-income countries. Until now, it's estimated that approximately 1.6 billion children who were learners were affected by school closures, and it's estimated that 16 million of them may never return to school. So school closures have kept 90% of all students out of school, and the reality is that remote learning remains out of reach for at least 500 million students, if not more, across the globe. Also, analyses have shown that school attendance causes or results or is associated with reductions in fertility, as you see by the graphs, reductions in child mortality, which could amount to approximately 51% reductions, and increases in empowerment. So what is the way forward? It's a difficult situation. There are papers that show that mitigation strategies, as Archana referred to, could reduce transmission in schools. Other papers have shown that glass barriers and opening windows can increase air circulation and reduce aerosol transmission of particles. But we should remember that only 75% of primary schools have basic hand washing facilities. And we should weigh up advantages and disadvantages and then chart a way forward. In South Africa, we've recommended a 10-point plan to help schools to become safe so that children can return to school. They focus particularly on non-pharmaceutical interventions, and they focus on infection control. They also encourage the use of outdoor spaces and physical distancing and conducting daily checks with staff and learners. A question often arises about multi-generational households, and we've put together a list of easy, practical things that can be done to limit spread within multi-generational households. And then if online platforms are needed, there are specific guidance that can be given. Accompany the online platforms with the implementation of mental health hotlines. Remember that teaching should not only be transactional, but it should be relational. Care for learners, teachers, and parents. And then there is an article about 4 key components that should be in a mental health toolkit, focusing on connecting the children with body and mind, connecting children with developing their identity and regulating their emotions, and then recognizing our interdependence. And so just to come back to my main points, and I'm almost done. So let us leave no child behind. Physical school contact is important for mental, physical health, to reduce child mortality, to reduce fertility and pregnancy, to reduce gender inequality and exposure to violence. We do have a global imperative to offer physical school attendance with precautions during COVID-19, or to reimagine schooling by creating physical learning pods, or by increasing coverage of accessible online platforms that recreate school environments that focus on not just the transactional nature of learning, but relationships and soft skills. Thank you very much.
Ameena, thank you so much for that talk. And, you know, we know how difficult it is and such a balance it is regarding schools, and such importance that children have been the really the collateral damage of, you know, probably less effect by directly, but these indirect effects, and particularly those with the school closures, have been really, you know, devastating. And certainly that was the impetus for us to get the schools open in our schools because of all the mental health impacts. So now we're opening now to the panel discussion, and I'd just like to ask Professor Kristine Macartney. So Kristine is the Director of the National Centre for Surveillance and Immunisation in Australia. And Kristine, we would welcome your thoughts and things that you would like to add, you know, and reiterate as part of the presentations, that we then reflect on any things and learnings from you. Thank you very much.
Oh, thank you, Fiona and Mark, for the invitation to be part of the panel. And thank you so much to Archana and Ameena for an incredible presentations. And it is amazing that in October, we've already generated so much data on the impact of this virus in young people, in educational settings. And I think, you know, we know how much, it's quite clear how important it is for children to be in schools. And I think we are having an increasing body of evidence that tells us, as Archana mentioned, that children themselves are not the super spreaders. But I think by the same token, we do know that schools will get caught up and they'll get wrapped up into communities when there is a lot of transmission going on. So I think that, you know, we see this complex mixture of transmission and schooling, and the need for a really, really strong coordinated response between education departments and health departments. And I would say that our own experience here, it was when that really started to work well that, you know, we felt in Australia at least we could absolutely start to get some traction in, and having those relationships work incredibly well is important. I think we shouldn't forget that schools are run by teachers who are adults, and we have to remember that messaging. We have to actually support teaching staff and, you know, school principals and everyone. And we have to think about, you know, those sort of the way that teachers live their lives too, actually, as they attend schools, because I know certainly evidence that's really coming out a little bit more strongly now of certainly from our own data that we may be seeing more transmission between, you know, high schools, older students, teachers, than we will certainly between, say, primary school age students. So in doing that, our COVID safe policies, that's what we call it here, but the name will be different everywhere, really do try and take into account of what teachers are doing. You know, are they carpooling to get to work together and not social distancing? You know, we have to support those who do the education as well. I think the other thing is thinking about how families move around together, and obviously also how public transport works. But there is a lot in the mix, and what I think is coming through, and this was a discussion on a WHO technical advisory group that I was on as part of about a week and a half ago, is using the evidence that we've derived now to encourage our policymakers, our governments, to see schools as one of the most essential services that we have. So to prioritise either school reopening when an epidemic is waning, or to try as much as possible maintain schools for face-to-face learning in when there is community spread, and have in place as a priority plans in those settings. And the example of Ireland was made whereby I think they have now gone into stage 5 lockdown measures, they are, according to their website, letting people only out for essential purposes, but in that context, keeping schools open. So I strongly believe that as paediatricians and as infectious disease specialists, we have a role to both advocate and demonstrate the evidence to those at the highest levels of education and health to prioritise, effective education for children, and use the scientific evidence that we have at our disposal as clinicians and those in public health to support our communities in doing so. Thank you.
Thank you very much, Kristine, for those reflections, and to the both Archana and Ameena for amazing talks. There's been a lot of questions asked about particularly masks. Some have been addressed by some of our panelists within the Q&A. I wondered if I could ask the panelists to talk a bit more about masks. I have, Professor Eben, who's the president of NSPID, the Nigerian Society, has commented that kids just aren't wearing masks in many places, and what do we do about that? So if I could ask for some more discussion about masks and what is the common sense approach within schools. Should we be draconian? Should we not? Which is what I think. And are we talking just about risk mitigation as much as we can? But I'd love some thoughts, more thoughts about masks and children from the panelists. I'm going to start with Ameena. If you can just give your thoughts about masks in addition to what's come from our experts on the panel.
Thanks very much. Thanks very much. I think mask wearing is a tricky issue, and it has to be context specific. There are several guidelines issued by the World Health Organization, and I think that each setting needs to assess what will work in that particular setting. And some of the principles that have been set in place are, firstly, let's do no harm. So let's put in place mask wearing, or let's put in place the strategy that's in the best interest of the child, and that includes fostering health and well-being and prioritizing this. So if we put in place a policy of mask wearing in a punitive way, that may not be in the best interest of the child, particularly children who are not at risk, not at high risk of getting COVID-19 or getting severe disease from COVID-19 or transmitting it to adults. And so the harm issue, one has to really think about who is at most harm, who are we trying to protect, and in this particular context, who should be compelled to wear a mask. The second principle is learning and development, and mask wearing shouldn't negatively impact learning and development. So this is particularly relevant to young children who are still learning to speak, as well as children who have developmental or other disabilities. And then thirdly, in the context, is mask wearing feasible? And so I think if we go back to basic principles, or these three principles, for every setting we should, or every context, maybe a district, or it might be a particular school, or it might be a set of schools. For example, early childhood development centers will have a different rule that may be applicable compared to high schools. And that our policies should then be guided and tailored to the individual setting. So I think that's just my first comment, Mark, and I'll hand over to others to also share their thoughts.
No, thank you very much. Any more comments from the panelists? And while you are thinking about it, I'm just going to give you my experience with masks, in that I initially thought that the WHO recommendation of not wearing masks made a lot of sense, and it was just complicating the issue. And then in the NEJM, I saw a video link of someone who'd set up a way of visualizing particles during ordinary speech and loud speech with and without a mask, and that visual evidence was enough to convince me that when you can wear a mask, you really must. And I will try and find that link and share it as well. So that's just my personal view on the masks. I don't see any other comments. Archana, I see you are ready to talk.
Yeah, I just wanted to say one thing, is that if you're going to implement mask wearing, you have to be able to educate, but it's also that you have to be able to wear it correctly. So we know that, in young children, in most settings, they can't really tolerate a mask. It can be a choking hazard in very young children, and so that needs to be considered as well. So one, is it, like Ameena said, feasible to wear a mask? There are benefits in wearing a mask correctly, but it needs to be worn correctly. And the age of the child, I think, is a big factor in terms of tolerability of a mask. I think in settings, and once again, this is my opinion, in settings such as public transport, where really you can't have physical distancing, and not only within your school community, you're within the public community taking a transport, then, there definitely is a role of mask in children who can tolerate it. In Australia, we recommend it for children above the age of 12. It might be different in other settings.
Thank you very much. I might, in terms of correct wearing of masks, about half the people I see don't have the mask over their nose. What do you think about that? Should we be improving our education to cover your nose when you can? What are your thoughts?
Definitely cover your nose, because that's the purpose of a mask. It can be quite intolerable, and I definitely understand. The other thing is also the removing a mask in a more aseptic manner. Don't just pull it, because that doesn't really help. So it comes with you have to wear it correctly, because if you just kind of rub the front of your mask, you take it off, and then you put your hand on your face, then it really defeats the purpose of wearing one.
Archana, can you just, for all of us, can you just describe the best way to take a mask off, just in case people don't know?
Yeah, so if you give me a second, I'll wear a mask and then I'll take it off.
Okay,
just one second.
Sure. No, that is fantastic. No, thank you very much. I'm just looking, we'll just let's see. Okay, great.
Actually, you're on mute. I'm not speaking.
Sorry, I was saying that it's covering my nose, around my face. I comfortably converse, but it has a good, seal. You can see it's fogging my glasses. So the way I take off a mask is, the way that we've been taught in infection control is that, you do hand hygiene, and then you try to peel it off, and you really don't touch the front or the inside. Like that. And then if you put it in a place to where, maybe to air it out, maybe to wash it, cloth mask, and then make sure that you wash your hands, or hand hygiene, before you put your hand on your face to scratch your pimple. Yeah.
Thank you very much. I'm assuming that teachers should all be wearing masks all the time and correctly wearing them. Would you agree with that it's really important for adults in the school setting to be super fastidious about their own personal safety?
I think certainly if there is community transmission, and it's definitely very wise some of the other things that have been, we have heard occurring with teachers is that there will be an increased distance between the teachers and the students, or, marks on the floor to, reduce the amount of contact between the teachers and the students. But of course, then you have things like pre-primary education or childcare where you can't distance yourself from the child. Someone who is looking after a 3-year-old cannot distance themselves from a 3-year-old. In our experience, at least, one of the most important things is that staff members are respected to, actually have their own space. So we found that, where staff members were gathering, they may be trying to social distance from the children, but not from each other. They were gathering in a staff room that was still very small and not well ventilated, and they were not social distancing from each other. That was a challenge. Now, every context is so different. So I think it's very much, though, about those adults who are staff trying to maintain all of the social distancing measures and adapting learning and face-to-face schooling in those ways. It is definitely so context specific that these principles need to, just be supported, I think, in policies that are tailored to context.
Thank you very much, Kristine. Ameena, please.
I'll just add something there. In my experience, social distancing is quite difficult to do in school settings. And it's easier in some of the preschool settings because they follow the teacher and they do what the teacher does and what the teacher says. But quite difficult amongst teenagers. I think they're at the age where they want to hug each other and be close to each other all the time. And so we need to think about those contexts as well. And in particular, I found that some people have or think that wearing a visor is alone. So visor alone is as good as wearing a mask. And that really is not the case. So the message that we need to get out there is that, if you are going to wear something, wear a mask rather than a visor. If you want to wear both, you may wear both, but don't wear a visor alone. And then the second thing is that, this issue of maintaining physical distancing is something that needs to be looked at. And it's something that is, I don't want to say context specific, but there are different, not different rules, but there are different needs of different age groups. And I think we need to take that into account, because that contributes to child development. The young child wants close contact. The kind of school-going child between 7 and maybe 10, they're quite happy to run about. They don't need that much physical contact. And then teenagers really want to belong and they need physical contact. So we need to take those 3 age bands into consideration as we think through how we implement social distancing or physical distancing.
Thank you. Could you just comment a bit more on the visor? That is one of the questions from Stefania. What are the benefits of a visor?
My understanding and reading of the literature is that the visor is really to protect the eyes. So that's, so if you have goggles, it could serve as a visor, it's the same function as a visor. So it really is to provide a screen to protect the eyes or to protect any splash of secretions onto your face, which you may then rub your face and put it into your nose or into your eyes. The advantage of a visor is that it can be cleaned and it can be reused, and it can be done that can be done quite easily. And so I think that's the added benefit of a visor, but it cannot replace a mask. I'm not sure if anybody wants to add to what I've said about the visor.
I'll post a paper on that. It essentially says exactly the same thing, Ameena. Yeah.
No, thank you very much. So I've got another question, which it's one from Arlene, who says that if a school attending child is COVID positive, what does one do with the exposed classmates? And then leading from that, another question is, what tests do we actually do? Do we do the nasopharyngeal swab, or is there anything that's easier and that is as reliable? And if the panelists could please comment on first Darlene's question and also the best way to get diagnostic specimens.
I think in respect to the contacts at school, where we have been able to see reduced transmission, I think quarantining those contacts, having them isolated then and home from school is really, I think, the most effective. It makes a lot of sense that if they're close contacts and you can then not have them return to school, this will reduce ongoing transmission. But of course, that needs to happen quite quickly, because the index case may have been at school for a period of time. You may already see transmission in schools. But certainly where I think there has been success is if those contacts are identified very quickly when there is a case, if they themselves can quarantine, if the school can be cleaned, if there is increased testing as much as possible around the school community to try and detect additional cases. And, insofar as if there are not a lot of additional cases, being able to keep the school open, I think is possible. But, it's really dependent on that strong health response. In our setting, we have had very strict quarantine. And so children are then, if they're test negative, allowed to return to school after 14 days, assuming that there is no ongoing outbreak in the school. And which test? Well, I think this is a question that is a complicated one. Obviously, if you have widespread or ready availability of nose and throat swab testing using PCR done in an accredited laboratory, that's probably the closest thing we have to a gold standard. But, I think that we are seeing some of the rapid tests with greater specificity now. Specificity is very important, and with improved sensitivity. But of course, they should be ones that are either well validated by WHO or FIND or by the local regulator in your country. We are also obviously starting to see the emergence of saliva-based tests, which again are being examined for their validity, for their sensitivity and specificity. And I think these tests will have a place in being able to support early management of outbreaks and response to outbreaks in places like schools and other settings. But the key message is that they really are well validated and well studied, and that we as an infectious disease community can support the use of those tests through evidence on their quality.
Thank you. A question directed to Ameena is the indirect effects of school closure on the availability of healthcare workers and the economy. Just to, if you or any of the panelists have any thoughts on that.
So, Mark, is the question about the effect of school closures on the availability of healthcare workers?
I think so. Joseph, if that's wrong, please just type in a clarification, and then the economy being in shutdown as a whole.
Yeah, I think as I mentioned, schools are necessary and they provide safe spaces for children to be in, whether it's an ECD center or a primary school or a high school, so that parents can work. And I think that with school closures, parents have been in a very difficult situation of not having childcare in many countries. In our setting, where we have clinical research sites and we run clinics, our staff have been in difficult situations for two reasons. Firstly, they don't have childcare, and secondly, they're still paying school fees, but there are no services available. And so to engage another childminder or to get somebody to come in to look after their children now would have additional costs. So they would incur additional costs. And so if you expand that to a global level with approximately 1.6 billion children not going to school, the effects are at several levels. It's not just on parents' mental and emotional health, but also on their physical health, coupled with the effect that it has on children's well-being, and then coupled with the effect on the economy. Because if parents are concerned about their children, and if parents don't have childcare for their children, then parents either reduce time at work or try to work from home. In often instances, income is affected. And so this really has a knock-on effect on the economy. So I'm not sure if I've answered the question adequately, but please feel free to add anybody else.
Thanks. I'm going to hand over to Fiona now also to just reflect a little bit and maybe start wrapping up and summarizing, and then any last thoughts from any of the panelists.
Perfect. Thanks, Mark. So we've heard, fantastic presentations on, really the overview of, schools and transmission and the, the absolute paramount importance of prioritising children in getting back to school and keeping kids at school, as much as possible because of all of these indirect effects and the unanticipated effects on children and families and their mental health and well-being and all sorts of things that go on. And certainly in our setting, so we're another state in Victoria, which had most of the infections in Australia, and even we kept schools open for essential workers, which are the healthcare workers and aged care workers and special schools and vulnerable children who were at risk, potentially throughout the whole epidemic period, and certainly through with our experience and analysis, very much echoed what New South Wales and Kristine and Archana have said in terms of, what we found was that when if there was low transmission and school mitigation measures and a rapid response, so if there was an infection in a school, shutting the school down, quarantining all the contacts, testing them, and, all of that, it was a very low risk of onward transmission. And so, in fact, most of our cases in our schools were not even an outbreak. There were single cases because of the public health response, even at the height of the epidemic and when that occurred. And I think that's really, it's just a really crucial thing that, and Kristine emphasised it so importantly, that rapid, the mitigation, because we do know that children transmit. There is no doubt that children transmit the virus. And I think this is probably quite confusing for people, is that children do transmit the virus. There is absolutely no doubt about that. And we may even need to vaccinate to prevent that transmission, if there was a vaccine that was safe and effective and prevented transmission. So we don't have to shut schools and we don't have to mitigate and all of these things. But because we don't have that, the most important thing is, as Kristine and everybody has said, is to mitigate that. And with all these public health responses, which is so important to then stop that onward transmission and then try to keep the schools open and prevent all these indirect effects. So there was just one question I really wanted to ask Ameena, actually, in your context, because in our context, we don't live in multi-generational households by and large. Most of the time, our parents, the elderly live somewhere else in their own home. And I was just wondering, I would imagine in your context and in many contexts around the world, that isn't the case. And what would your advice be when there is moderate to high transmission and many of the households, we know most transmission occurs in households. particularly, related to schools and school infections. So what would your advice be to countries? Because we've had these conversations. There was a question from Indonesia, for example, who are in these circumstances. So I'd be really interested in hearing in your advice and what you do.
Yeah, thanks. I think that's a really tricky question. And at some point in South Africa, we said that, try and don't visit grandparents. But if you live in a multi-generational household, then what do? Is the household big enough so that grandparents and elderly relatives can stay in one part of the house, and the rest of the family who's going out to work, perhaps if they're essential workers or kids going to school, can they stay in another part of the house? That might work in some settings, but doesn't work in many households in South Africa, where you have grandparents actually looking after and being the primary caregiver of young children. In that case, it's difficult, and it's a way up of at what stage of the epidemic are you? Is there large-scale community transmission? So your question related to high-risk, high transmission. So if it's high-risk, high transmission, and if the school is in a setting where they're struggling to provide the basic NPI non-pharmaceutical measures, and classrooms are very large with poor ventilation, then for that period of time, it may help to keep the child out of school. But as soon as infections have reduced and you see that the overall trend in the community is towards lower transmission, or if you're in a setting where non-pharmaceutical measures can be observed, the child can wear a mask, you can sanitize, and at home you can keep a reasonable distance. I think what is a safe distance? And people keep asking, is it a meter? Is it 1.5 meters? Is it 2 meters? And I think the reality is the further away, the better, right? But if you had to choose a particular distance, let's say don't come closer than a meter. So let's keep away by at least a meter, more if possible. Let's make sure that there's ventilation, so households have windows open. And then if you do have to be in a household where you have a multi-generational family setup, then try and avoid close contact for prolonged periods of time. And the advice that we're working on, or the numbers that we're working on, is don't be with somebody for more than 15 minutes at a meter or less. And so these are not perfect. They have to be not just moderated, but they have to be tailored, and they have to be observed. So it's not perfect, it's not easy, but these are some of the things that we're advising on our side, because many of the poorer households have a room or, 2 rooms, and everybody stays in there, or you have grandparents looking after young children who are orphaned, or parents are away working elsewhere. So that's what we're sticking to. Yeah, so follow the epidemic curve, and if you are going to school, then try and reduce the contact, and we're using the 15 minutes and not less than a meter. Mark, I don't know if you want to add.
No, I think that sounds great. Thank you. I'm going to wrap up now and just address a conversation with a question from Reiko Saito from Japan that was answered by Kristine, and it was that in Japan, with a COVID case, the school is closed for 1 to 2 weeks, and Kristine responded that in her setting, really 24 to 48 hours might be enough to look at the extent of the spread and then reopen the schools if you can. So that's a very good practical advice, and thank you for that. So we are now going to close this excellent session. I must say I've learned a tremendous amount. I want to thank all of the speakers, my co-chair Fiona, Ameena, and Archana for giving brilliant talks, and Kristine for amazing insights that you've given, and to Hester for behind the scenes organizing everything and sending messages about the online availability of the talks. And I think the slides as well, I think the speakers will have to give permission for their slides to be released, or which slides, sometimes, there's an embargo on some things possibly. But anyway, thank you very much. And then once again, it's really been great having this discussion and learning so much. And thank you so much to all of the attendees who've supported the webinar and participated with great questions. We will be having another webinar in round about a month. We do again have, for CME, we have a pending registration. We don't know if it will be there on time. We've also arranged for CPD for South Africa, but don't have the permission yet. But hopefully we will get that. And then to then close the session, and thank you so much to all for this really great webinar. And goodbye and keep safe. Thank you. Okay, bye everybody.